Welcome to AETCM, the emergency medicine channel. Today let us discuss about one of the common electrolyte imbalance in emergency room, that is hyponatremia. Hyponatremia means reduced salt state in our blood. It may be real hyponatremia or pseudo hyponatremia that we will see afterwards. Whatever it is, if the patient is having symptoms of hyponatremia, only we have to treat. Otherwise, it is not recommended to treat with either IV medication or oral medication for this asymptomatic hyponatremia. That patient may be fully compensated. We should not unnecessarily produce more complication in that patient. We will see what are the causes, how do we manage all these things. Hyponatremia is defined as plasma sodium less than 135 milliequivalents per liter. That means normal sodium is 135 to 145 milliequivalents per liter. Here it is less than 135. We can call it as hyponatremia. But when we are managing hyponatremia, if there is a clinical finding, we should treat the patient in the emergency room. Otherwise, we should identify what is the reason for hyponatremia, and if possible, physiological management will be best. That means more salt intake, increase water removal from body, like that. Physiological treatment will be best for hyponatremia in most of the conditions. Whenever there is hyponatremia, you can see the serum osmolality is low. Real hyponatremia, it will be hypoosmolar hyponatremia. If the osmolality is very high, then there is some other cause, or if the osmolality is normal, also some other cause for hyponatremia. That is not real hyponatremia. So pseudo hyponatremia means normal osmolality. It can be due to hyperlipidemia, hyperproteinemia. Like hyperlipidemia is very common in nowadays because of high cholesterol levels in patients due to genetical reasons, not because of the diet and all. Diet and all will produce only mild elevation in the cholesterol. That may not produce any hyponatremia, but due to some genetical deformity, the cholesterol levels may be very high. That produces abnormal sodium. Hyperproteinemia can be seen in conditions like multiple myeloma and all. There also you can get this false hyponatremia. High osmolality mainly seen in high blood sugar. That is very, very important. When the blood sugar increases, you can see the sodium levels are actually coming down. It's only reflected in the lab parameters. Patient will be absolutely normal. Patient actual sodium is normal. Because of the high blood sugar, it is shown as a hyponatremia. You can calculate the corrected sodium by this formula. Every 100 milligram per deciliter of glucose from the normal value, you have to add 1.4 to the sodium levels what you are getting in the lab investigation, so that the corrected sodium may be higher. If 400, then for 1.4, 1.4, 1.4 plus 1.4 can be added to 4 times 1.4 can be added to your basic sodium levels, so that the sodium level we can see that actual sodium levels are increased to normal. Now there are 3 important types of hyponatremia. That all depends on the body water, because sodium and water has got similar space or almost all areas in our body. So the water level and sodium levels are highly dependable. So whenever there is water increases, you can get hyponatremia. Some conditions you can get both water and sodium will be decreased. Some conditions only sodium will be decreased. So depending on that condition, first test tube, it's only a representative diagram. First test tube we are seeing water and sodium. Second one is hyponatremia with normal volume. That means water is normal, sodium has gone down. That means suppose patient is not taking adequate sodium, but he is taking water. So what happens is water levels are normal, sodium level is low. That is normovolumic hyponatremia. Second condition, you can see volume levels have increased, the salt level is actually normal. The conditions are like cardiac failure, kidney failure, liver failure, hypoalbuminemia. All these conditions patient will develop generalized edema, more fluid retention, but most of the time the sodium is normal, but it will reflect in your lab investigation as hyponatremia. This is hypervolemic hyponatremia. The last one is both water and salt is reduced. Suppose the patient is losing large amount of volume with salt, like vomiting, diarrhea, some conditions like that we will see in detail afterwards. Like a patient who is having continuous diarrhea, he loses both water and salt from the body through the stools, so he can have hypovolemic hyponatremia. So three important types of hyponatremia: normovolemic, hypervolemic, hypovolemic. In that hypervolemic, actually the sodium is normal, so no need to concentrate on the sodium levels, you have to concentrate only on the water levels. Whereas in the first one, normovolemic hyponatremia, you have to increase the salt, that's all, no need to cover the water, water is normal. Last condition is both salt and water is reduced, so both has to be corrected. So we can see the conditions. First we will see hyponatremia with normal ECF volume, syndrome of inappropriate antidiuretic secretions, hypothyroidism, glucocorticoid deficiency, post-operative pain, psychogenic polydipsia. All these things are most common, and that first two conditions like hypothyroidism and SIADH is very common in clinical practice. Hyponatremia with increased ECF, we have already told, volume is expanded due to cardiac failure, cirrhosis, nephrotic syndrome, renal failure. This is otherwise called as dilutional hyponatremia. Third one is hyponatremia with low ECF. Patient is having water loss with sodium loss. Renal loss can be due to diuretics, osmotic diuretics, like patient may be on mannitol or high blood sugar, salt wasting nephropathy. Extrarenal cause, vomiting, diarrhea, peritonitis. So these are the common causes for hyponatremia. The most common thing which will come to your clinical practice will be hypervolemic hyponatremia, and SIADH also you can get in some patients. Other conditions like large causes like volume loss with hypovolemic hyponatremia, main thing is diarrhea, vomiting, diuretics and all. SIADH is a special condition, we will not go to the details of that, we can discuss it afterwards. Here ADH release is like there is a syndrome of inappropriate ADH secretion, means persistent ADH release and water retention can be seen in SIADH. The problem here is water retention. Any patient who is having SIADH will have more water retention than salt retention. Salt will be removed from the body. So that produces hyponatremia with hypervolemia with increased sodium excretion through the kidneys. But if you examine the patient, there is no clinical findings of hypervolemia. Clinically, patient is not having edema or pitting edema or anasarca, facial edema, nothing is there. Clinically, you cannot find any edema, but inside the body, inside the cells, inside the vascular compartments, volume is slightly expanded and sodium is lost through the kidneys. So it's actually a volume expansion condition, but we are not clinically seeing any edema in this patient because there are some counter regulatory mechanism. They try to remove this excess water, but still water is in excess state, somewhat excess state with exaggerated sodium removal from the body. The major causes are lung malignancies. There are a lot of other causes like drugs can be responsible for that. Post surgery can be responsible for that, but the most important conditions are lung malignancy and some other malignancy produces paraneoplastic syndrome. So here there are three important things: low plasma serum concentration, sodium is low in the serum, low plasma osmolality, that means it's a real hyponatremia, not a pseudo hyponatremia. Third one is urine osmolality is elevated, that means urine sodium is more, urine excretion is more. Normally when there is a hyponatremia, urine should try to retain sodium inside our body, it will not send out the sodium through the kidneys. But in SIADH, even when there is hyponatremia in the body, urine there is a loss of sodium, that is very important. So SIADH is classically presenting with increased urine sodium output. Now, clinical features of hyponatremia, it mainly affects the cell, especially in the neuronal cells. So, patient can have anorexia, headache, nausea, vomiting, lethargy, personality changes, muscle cramps, muscle weakness, confusion, ataxia, drowsiness, diminished reflexes, convulsion, coma, death. These are the common conditions. But in emergency room, you can see hyponatremia means drowsiness. That's a classical finding. And some patients present with encephalopathy and coma. Rarely patient develops with seizures. That occurs only in severe hyponatremia. Then when we compare with acute hyponatremia and chronic hyponatremia, acute hyponatremia have more symptoms than chronic hyponatremia. Chronic hyponatremia, most of the time patients are stable, patients are having mild drowsiness or mild confusion, whereas in acute hyponatremia, patients will have severe confusion, severe altered behavior, and some patients can present with refractory seizures also. Now, normally when we ask for serum osmolality, you can get the serum osmolality from the lab itself, but you can calculate the plasma osmolality 2 into sodium, glucose by 18 and BUN by 2.8. You can calculate the osmolality by these values. Normally it is 275 to 290. In hyponatremia, true means it is less than 275. That is very important, or less than 270. That is true hyponatremia. You can see here hyponatremia, low serum osmolality, that means true hyponatremia. Normal serum osmolality means hyperlipidemia or hyperproteinemia, you have to rule out. High serum osmolality, you have to rule out hyperglycemia or mannitol. So, whenever you get hyponatremia, always try to calculate the plasma osmolality, or some lab itself they give calculated value of osmolality. If it is available, see the osmolality or calculate the serum osmolality and see that it is less than 270, then it is a true hyponatremia. Now, urine sodium and urine osmolality, these are the second two important investigations, because when there is hyponatremia, actually there should not be any renal loss of sodium. Body will try to retain the sodium inside our body. It will not send the urine. It will not send the sodium through urine. That is a check mechanism. That means urine will not be removed through the kidneys when there is hyponatremia. But here, in some conditions where there is hyponatremia, that is due to the problem in the kidney, like I said, in the antidiuretic hormone, kidney will be continuously losing sodium in spite of body is having a hyponatremic condition. So, urine sodium concentration is very, very important. If the urine sodium concentration is more than 20 milliequivalents per liter, then it is a diagnostic criteria for SIADH, salt wasting nephropathy, diuretic therapy, hypoaldosteronism. These are the common causes. In that, diuretic therapy is the most important cause we come across. Both water and salt will be removed, but more salt will be removed from the kidney in sometimes. So, SIADH, salt wasting nephropathy, diuretic therapy, hypoaldosteronism are the most common causes. If it is less than 20 milliequivalents, the loss is due to an extrarenal condition like diarrhea, vomiting. And you should know that if the sodium loss through the kidneys are more, the urine osmolality will also be high. So, in a condition like SIADH, urine osmolality is more than 100 milliosmol per kg. That is a normal dictum. When the sodium is passing through the kidneys without any control, then osmolality also will be increased. So, that is very important. Hypotonic hyponatremia. That means when the hyponatremia is there, normally the tonicity of the plasma will be low. That is a true hyponatremia. Hypotonic hyponatremia means it's a true hyponatremia. Again, it is divided into hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia we have seen in the previous slides. Just few examples you remember. Hypovolemic means both water and salt is lost. Diarrhea, vomiting. These are the two important conditions, and sometimes diuretics. Euvolemic means it is SIADH, syndrome of inappropriate antidiuretic hormone. Here actually there is water retention in the body, but clinically you don't see any edema. That's why it is euvolemic hyponatremia. Third one is hypervolemic hyponatremia. There is a condition which produces volume overload in our body. It can be cardiac failure, it can be liver failure, it can be kidney failure with water retention, hypoalbuminemia with water retention. So these are the causes for hypervolemic hyponatremia. Other hyponatremias, we have already seen that hypertonic hyponatremia and isotonic hyponatremia. So both these conditions are pseudo hyponatremias. Actually there is no hyponatremia here because of conditions like hyperlipidemia, hypercholesterolemia, hyperproteinemia, hyperglycemia, mannitol, all these things. Sodium is abnormally low, which is shown in the lab investigation. That's all. Actual sodium in the body is normal. So plasma osmolality is the main diagnostic test once you know that hyponatremia is there. So when the patient comes with hyponatremia, check the sodium level which is less than 130, then go for plasma osmolality. If plasma osmolality is low, then it is a true hyponatremia. Then check the patient whether the patient is having a hypovolemic status, euvolemic status or hypervolemic status. Hypervolemic status means it's only dilutional, no need to do anything for the sodium. You treat the condition, like cardiac failure means you give diuretics and all. Euvolemic or hypovolemic, then that is very important. If the patient is having hypovolemic hyponatremia, both sodium and water should be corrected. If there is a euvolemic hyponatremia, only water should be removed from the body. Sodium can become normal after that. If the sodium is not normal after correcting the volume status, then only you have to give sodium and drugs which can prevent the urinary loss of the sodium. That we will see afterwards. In that, urine sodium has got an important role because we should know whether the urine sodium is more than 20 milliequivalents per liter or less than 20 milliequivalents per liter. So that can be done in all patients. So these are the basic investigation we will be doing in patients who is having hyponatremia. So hyponatremia, always check clinically, always check the patient is having hypovolemia. So hyponatremia patient, always check for hypovolemia, dehydration, hypervolemia and clinical edema, normovolemia. But remember, in SAIDH there is actual water retention. You are not seeing that in clinical examination. That's all. Now once you diagnose sodium deficiency, we have to correct it either by oral correction or IV correction, whatever it is, we have to correct it. So in a normal patient who is having a mild sodium deficiency without any major clinical finding, you can give oral salt. 1 teaspoon sodium chloride contains 6 grams of sodium. That is very important. Normally we take 6 to 8 grams in our diet, daily diet. So 1 gram sodium chloride contains 17.1 milliequivalent sodium. 1 tablespoon of salt contains 18 gram of sodium. All these things, values are very important when we practice in OPD. Extra salt can be given as salt tablets. Salt should be filled in normal capsule like B complex tablet. You can take and remove the content from that and fill the salt in that, give to the patient, because directly you are giving salt through oral route, it will be very difficult for the patient. It may not be palatable for the patient. So if you have a Ryle's tube, then it is easy, or you have to remove this capsule content and fill the sodium in that and give. So one thing you should remember is normal Indian diet contains 6 to 8 grams, and if you want to give additional salt, it has to be suppose you want to give extra 2 grams salt, it has to be 10 grams salt per day. Each gram contains 17.1 milliequivalent salt. So that is also very important. So these values we should remember when we are treating. Now if the patient is having both water and salt reduction in the body, then you can give IV fluids. In that, most important IV fluid will be 0.9 saline therapy. That means normal saline therapy. Normal saline 0.9 normal saline contains 154 milliequivalents per liter. So 500 may contains around 75, 76 like that. But 3% saline contains 513 milliequivalents per liter. But it is available as only 100 ml bottle. So it will be 51.3 milliequivalents in one bottle. So these values you should remember. Others are less important when we are treating hyponatremia. So 3% contains 513 milliequivalents per liter. It is available as 100 ml bottle. 0.9% normal saline contains 154 milliequivalents per liter, but it is available as 500 ml saline. So 3% saline, when we are giving, we have to always know what is the amount of sodium which is sodium deficit in the body, and you can calculate the required sodium by this formula: desired sodium minus serum sodium into 0.6 into body weight kg will tell you what is the actual deficit. Suppose it is 130, then you 120, suppose it is 120, then your desired sodium, if it is 130 or 135, you have to put it as 50, desired sodium minus serum sodium will be 15 into 0.6 into body weight will tell you what is exact amount of sodium required for the patient. Then you should understand that each 1 liter of 3% saline contains 513 milliequivalents. So 100 ml contains only 51.3 milliequivalents. Then you can calculate what is the amount of 3% required to correct this hyponatremia for the patient. But this is only a total correction we are calculating now. So it may take several days to correct that. So we need to give 3-4 bottles of 3% saline in a day, and it takes 5-6 days to correct the total deficit, because any hyponatremia, whatever you calculate, that should not be corrected in a single day. You need to give time, otherwise patient will develop neurological complication. Maximum correction can be done in a day will be 8 to 12 milliequivalents per day. That's all. Suppose it is 110 today, tomorrow by this time it has to be only 122 maximum, 110 to 122 maximum. So 8 to 12 milliequivalents only should be corrected in a day. So that is very important. Now for example, a 50-year-old male patient, 70 kg with sodium is 110. Desired sodium for tomorrow, that will be 122 milliequivalents per liter. So the sodium deficit can be calculated like this: I want 122 by tomorrow. By 110 should be reduced from that. Then it is same, that is 12 milliequivalents into 0.6 into 70. So 12 into 42 will give 504 milliequivalents. 100 ml of 3% saline, one bottle contains 51.3 milliequivalent sodium. So 504 by 51 will give actual amount of bottles that I require, around 10 bottles of 100 ml 3% saline in 24 hours. So per hour infusion will be 940 ml per 24 hours, 980 ml per 24 hours. Each hour should be around 40.8 ml should be given per hour. But only thing, these are calculations done by clinical features. But when we are transfusing this much amount of sodium, always check the sodium. Some patients respond faster than other patients. Their sodium levels, due to some reason, they shoot up very fast. So every 4 to 6 hours we have to check the sodium, and in 24 hours, any time if it reaches nearly 10 to 12 correction, then stop the infusion. Do not cross it after that. Do not continue it after that, unless until patient is having a severe deficit. If the deficit is severe, you can correct it little more. Otherwise, don't try to correct, especially chronic hyponatremia. Acute hyponatremia you can correct little faster, but chronic hyponatremia, if you try to correct faster, patient develop neurological complications. Now, if the patient, when we are correcting, always correct up to 130, that is enough. If with IV 3% saline, after that try to correct with oral solutions, oral salt or Ryle's tube feeding, we can correct the sodium. So up to 130 you can correct with this type of correction. Slow correction is always better than faster correction. In severe neurological symptoms, like patient is having severe altered behavior, coma, seizures, all these things, you can go a little faster. 3% saline, 100 ml or 10 to 60 minutes, 2 ml per kg per hour can be given. So, but that should be only in emergency, like a patient is having seizure, severe neurological complication, then only you should correct in this fashion. Otherwise, never try to do this. Now, if you correct faster in a faster manner, if you try to correct the hyponatremia, especially in chronic hyponatremia, they develop a condition called as osmotic demyelination syndrome. This is sometimes called as central pondine myelinolysis or extrapondine myelinolysis. Central pondine myelinolysis means myelinolysis occur in the pons area. Extrapondine means extrapondine areas myelinolysis will be there. Patient can have altered behavior, patient can have paraplegia. All these complications can occur due to myelinolysis. So we have to be very careful. Do not try to overcorrect or do not try to correct in a faster way for hyponatremia. SIADH treatment will be initially we know that it is a water retention condition. So try to remove water. First strategy will be remove water. So the two important steps are restrict the water first. So try to restrict the water to 500 to 100,000 ml per day. So the water content in the body may come down. Then give Lasix, furosemide. Then add salt to the diet. So 3 important strategies initially. Most of the patients will respond to your initial treatment plan. But if the patient does not improve with the initial treatment, and if the patient is symptomatic because of hyponatremia and it is not controlled with your traditional treatment, give 3% saline. What is written in the previous slide, go according to that chart and try to correct the sodium. But here there is a problem in SIADH. Urinary salt loss is there. The reasons are multiple. It may be due to malignancy, it may be due to paraneoplastic syndrome, it may be due to drugs. So try to stop the drugs, treat the malignancy. Even then, we have to prevent the loss of the sodium through the kidneys. So we can give some drugs like tolvaptan, conivaptan. In that, conivaptan is available as IV, tolvaptan is oral. So they are called as vasopressin receptor antagonist. Tolvaptan oral 15 mg OD can be given. Even he can increase slightly higher doses can be given. But remember, when we are continuously giving tolvaptan, always check the liver function test. That is very important. If there is a liver function test alteration, try to discontinue the drug. So we have discussed about hyponatremia management in emergency room. Hyponatremia is one of the most important condition, most common condition in emergency room. But remember, many patients with urinary tract infection, they also have hyponatremia. That is because of the acute renal injury produces renal loss of sodium. If you check the sodium in this patient's urine, it will be high. But we don't use this. We don't use tolvaptan in this type of condition. Even when we are getting a same pattern of SIADH here, we don't use tolvaptan in this type of patients. We try to treat the patient with saline or 3% saline or increased oral intake and antibiotics. But other conditions, hyponatremia can present with the commonest presentation will be drowsiness, weakness, encephalopathy, seizure disorder, coma, all these things. If the patient is fully stable, try to correct the sodium with oral salt. If the patient is having a mild sickness, try to correct the sodium with like normal saline. And if the patient is sick, try to correct with the 3% saline. If the patient is having volume overload, try to remove the volume. If the patient is having SIADH, try to restrict the volume and try to remove the volume. Then tolvaptan, conivaptan are the drugs which are available to prevent the urinary loss of sodium. The only problem is if you try to use tolvaptan, conivaptan in conditions where there is no renal loss of sodium, then that will be dangerous. Conditions like cardiac failure. If there is a cardiac failure or liver failure or kidney failure, you can see that there is a dilutional hyponatremia. Some patients can have altered behavior because of the primary problem like hepatic encephalopathy, uremic encephalopathy, toxic encephalopathy. They can have encephalopathy, but lab wise they can have hyponatremia. So here giving 3% saline or giving tolvaptan will be dangerous, because in a patient who is having liver failure or cardiac failure, if you give 3% saline, that will produce further water retention and further hyponatremia. And if you give tolvaptan in liver conditions or kidney conditions or cardiac conditions, it can produce sodium retention. So again it will become a problem. But tolvaptan nowadays, there are trials available which says that it may be beneficial in cardiac failure. So that guidelines have not been published, so we have to wait for the guidelines to tell whether it can be used or not. But nowadays there are a lot of trials which is going on whether tolvaptan can be used in cardiac failure or not, but that is only trial. At present there are no guidelines. So hyponatremia is very common in our clinical practice. We can control the hyponatremic symptoms with water restriction, water removal, 3% saline or normal saline, or tolvaptan depending on the clinical scenario. There are no other investigation other than 3 important investigation available to understand what is the problem. It is serum sodium, serum osmolality, urine sodium with urine osmolality. So these 4 investigations are very crucial to diagnose the problem behind hyponatremia. So whenever we see hyponatremia, always try to take these 4 investigation before trying to treat the patient with tolvaptan or 3% saline or normal saline. That is very important. And clinically we have to examine the patient whether it is hypovolemic patient, hypervolemic patient or normovolemic patient. Thank you.